I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine. I'm also the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. So there is an evolving role for the potential use of chemotherapy with an EGFR TKI for patients who harbor an EGFR mutation for lung cancer patients. Remember, patients with lung adenocarcinoma, roughly 15% of these patients will harbor an EGFR mutation. And we know that's important because if we can identify the mutation, we can obviously select the right therapy. And we've learned probably 5-10 years ago that first generation TKIs, or erlotinib, gefitinib, when they were compared to chemotherapy in advanced adenocarcinoma patients with EGFR mutations, there was a benefit in terms of response rate and progression-free survival with a first generation TKI versus chemotherapy. And fast forward now, we've got a next generation TKI called osimertinib, which has been compared head to head to the first generation TKIs, or erlotinib or gefitinib, in the FLORA study. Again, patients with adenocarcinoma, stage 4 lung cancer, harboring an EGFR mutation, there was an improvement in progression-free survival with osimertinib versus first generation TKI, and there's improvement in overall survival. Around the same time that trial was being done, we were also starting to look at the role of chemotherapy up front with a first generation TKI compared to a first generation TKI alone. So there's been two studies, essentially one out of Japan and one out of India, that have specifically looked at patients, advanced adenocarcinoma patients harboring an EGFR sensitizing mutation, and randomizing them to either a first generation TKI like erlotinib or gefitinib versus erlotinib or gefitinib plus chemotherapy. And the whole question being asked is, if we layer in chemotherapy with an EGFR TKI, can we do better than an EGFR TKI alone? And what we've learned from these two studies, from Japan and from India, is that there is an improvement in progression-free survival by adding the chemotherapy up front. And there is, importantly, an improvement in overall survival. And there's a lot of biological rationale while this may be the case. And I think we've had to look back and try to understand why these two studies have shown this overall survival signal. And I think a lot of us feel that there's a lot of heterogeneity up front in a lung cancer. And that while we've identified the quote unquote driver in the EGFR mutation, that there are other pathways at play that maybe are not tackled by single agent TKI. And that adding chemotherapy may knock out those other pathways. And that is what led to the observed overall survival that we saw, is that, yes, EGFR TKIs are important in EGFR mutant lung cancer, but there may be tumor heterogeneity going on. And by adding chemotherapy up front, this is what can lead to improvements in outcome. Remember, the Japanese study and the Indian study were looking at chemotherapy with a first generation TKI, but I told you prior that next generation TKI with osimertinib is the standard. So how do we build on the lessons learned from these studies and move it forward? Well, we don't know yet whether chemotherapy plus osimertinib is better than osimertinib alone. We know thus far that chemotherapy with erlotinib is better than erlotinib alone, or chemotherapy with gefitinib is better than gefitinib alone, but we don't know if those same rules apply with osimertinib. Now that osimertinib is the frontline standard of care, there is an ongoing study with FLORA-2. This is a randomized study, a clinically meaningful trial, looking at patients with advanced adenocarcinoma of the lung harboring an EGFR mutation, a sensitizing mutation, randomizing them to either osimertinib or osimertinib plus chemotherapy. And this hopefully will solidify chemotherapy as a potential standard with a TKI. Now, the things to look out for in this trial obviously will be the outcomes. We'll be looking at progression-free survival, but more importantly, looking at overall survival, but also looking at toxicity. Obviously, when you add in chemotherapy to osimertinib, And we saw this in the other trials. There was more toxicity with the combination of chemo TKI versus the TKI alone. Will we see that with osimertinib with chemotherapy? My guess is we will. We'll probably see more cytopenias, obviously. We'll probably see more GI toxicities. And my question will be, will the benefit be worth it? And I guess we'll wait and see. But I think that there's a lot of rationale to do this. There's scientific rationale. This trial has traction, and we'll hopefully have answers soon of whether or not adding chemotherapy to osimertinib is better than osimertinib alone, specifically in patients with advanced adenocarcinoma of the lung harboring an EGFR mutation.